I hope you all are safe and healthy at your respective homes and using this time to learn new skills. Of course, improve your health and spend time with your loved ones. My sincere thanks to all of you and to the forces behind you. Today, we have gathered virtually for a IASSA series on a keynote session, and our first speaker is going to be Dr. Gautam from Hyderabad. We have our international faculty with us today, Dr. Mustafa Garek from Turkey, and of course, we have Dr. Vikas Agarwal from Mumbai, who is also going to be our moderator of the day. I take this opportunity to welcome all of you from the bottom of my heart and hope that entire audience will enjoy this session also like our previous ones. With this, over to you, Vikas, Dr. Vikas.
Thank you very much. At the outset, let me take the opportunity to thank Sun Pharma, the whole team, for supporting this program. This is the 12th in the series, the second one of the keynote series. 10 of the series we had done on different topics of obstructive sleep apnea. And we are very, very lucky to have two prominent speakers, Dr. Mustafa Gerek from Turkey, who is the chairman of the Department of ENT and Head and Neck Surgery at Gulhane Medical School, Turkey. He's the president of Turkish Rhinologic Society with special interest in management of OSA, and he's having a vast experience in managing patients with, especially with tongue-based obstruction, and he does all kinds of surgeries, be it coblation, be it robotic, be it tongue suspension, and be it hypoglossal nerve implant. The other person we have today is Dr. Gautam Dandukri from Hyderabad, who is a maxillofacial surgeon. And we know that when soft tissue management is not inadequate or not appropriate, when the skeletal profile is not good, then we require help of our maxillofacial colleagues. So Dr. Gautam has been actively involved in holistic management of obstructive sleep apnea, especially with our friend Dr. Srinivas Kishore. And he has now the largest series of patients having undergone MMA as a treatment of OS in India. So that's a big thing. He's got the largest series. So with these two eminent speakers, I would like, in fact, Dr. Gautam to start the presentation on how to expand the box. We say that if the box is small, make the box larger. If the soft tissues are large, make the soft tissues smaller. So the concept for the ENT surgeons who we are already used to, making their soft tissues smaller. Now, Dr. Gautam is going to tell us how to enlarge the box if the contents are not fitting into it. Dr. Mustafa is there with us. We were supposed to start with Dr. Mustafa, but he had some problem in the slides appearing right now. So we are starting with Dr. Gautam. So may invite Dr. Gautam to start with his presentation on maxillomandibular advancement. Dr. Gautam, over to you.
Thank you so much, Dr. Vikas.
So while Dr. Gautam is presenting, I'll be muting and switching off the cameras of everybody else, including me.
Yes. Make this big. Share screen. Yes.
Can you share your screen?
Yes.
Yeah.
Are you able to see the?
Yes. Go to the top of this. Yeah. Make it full screen.
Full screen. This we can reduce. This window we can reduce. Yes.
Okay, can you all hear me now?
Yes, we can.
Right.
Perfect.
So I was asked to speak on this subject of maxillomandibular advancement as a treatment option for obstructive sleep apnea. Let's start with some of the patients we've seen over the years. And quite clearly, when we look at them straight away, and the more of them we are seeing now, we begin to realize that somehow they all present with a very shortened lower third facial height. In a normal individual with a proportionate aesthetic profile, we expect the face to have been divided into 3 equal thirds. The hairline to the brow to the column of the nose, and the column of the nose to the chin. Now, these 3 should be in equal proportions. But invariably, we find in these people that they have a shortened lower third, which is the distance between the column of the nose and the chin. And that signifies some sort of retrogenius. If you actually look at all these pictures, you will probably appreciate the fact that all of them are retro. You know, the lower third is somewhat pushed backwards. And therein probably lies the problem with their sleep apnea. So why MMA? Why is MMA now considered a gold standard in the treatment? Is because it enlarges the entire pharynx by pulling the tongue, the soft palate, and the anterior pharyngeal tissues. Now, all of this in one surgery is what makes this procedure very unique. Who needs MMA in the first place? So people with moderate to severe sleep apnea, with obstruction at multiple levels, failed CPAP. We all know that that would be the first line of treatment for any of the patients who present to us. But people who have bad experiences or non-compliance with CPAP are probably those people who might be advised this. Failed oral appliances and other craniofacial abnormalities, and class 2 malocclusion. Now, this is a very significant finding, because all those pictures that I showed you of facial profiles a while back are all class 2s, which means the lower jaw is slightly positioned more posterior than the upper jaw. And that's exactly why the tongue tends to fall back more when they're in supine positions. So how does it happen? Just to give you a little idea, I will be showing you a video of the real-time surgery later on, but just to give you an idea of how this works. Please have a look at this. So that's the airway we are talking about, which is quite constricted, and that's what the size of an ideal airway should be. So arch bars or braces, as the case may be, followed by osteotomy cuts in the maxilla and the mandible, and bringing the entire complex forward. So when we do that together, we don't disturb the occlusion. The orientation of the teeth remains as it was before. And in addition to that, we do a genioplasty, and rigid internal fixation goes on to hold the skeleton in that position after the surgery. So that's where we have gone from there to there, and that automatically expands, as Dr. Vikas was saying, the box, which makes it more ideal and probably less problematic to the patient. Pre-op preparation is surprisingly, for the extent and the of the surgery and the complexity of the surgery, pre-op preparation is actually very minimal, because all we need to do is take a few dental models and casts and prepare wafers, which actually help us to position the jaw in the right orientation and occlusion intraoperatively. These casts are mounted on what is called either a semi-adjustable or a fully adjustable articulator, so that we have the right orientation of both the jaws with respect to the temporomandibular joint, which is absolutely critical, because if this is not done, then we could end up with some malocclusion after the surgery or secondary temporomandibular joint disorders. Simple plain radiographs are enough. An orthopantomogram is what you see on the left-hand side, and a lateral cephalogram is what you see on the right-hand side. The orthopantomogram tells us a little bit about the orientation of the teeth. It's ideally any impacted wisdom teeth like these that you're seeing on the orthopantomogram on the left side should be removed at least 6 months before we plan this sort of a surgery. Now, what does the literature tell us? I mean, the evidence tells us that both I picked up evidence, looked at the literature in both ENT and as well as maxillofacial journals, and this was a long-term study done for maxillomandibular advancement as an option for treatment, and this was published in the ENT journal. And looking at the intermediate, long-term, and very long-term results based on all the criteria that you're looking at on the right-hand side, they came to the conclusion that in the short term, patients actually had a very acceptable AHI, and in the very long term, although it was 23.1 on average, it still reflects that there was considerable benefit to the patients following these procedures. However, there were some predictable factors in their study. So patients who were less than 45 years did better with the surgery, and patients with maximal advancement of the maxillomandibular complex in terms of anything more than about 10 millimeters, the average here was 12.2, which in my opinion is a bit difficult to do, but if 12.2 is what they achieved, that was great. And these are the patients who had much more advantage from this surgery. So in summary, that study showed us that the overall surgical response rate was 85.5 with a cure rate of 38.5. There was another study done by the maxillofacial surgeons, a 15-year review of patients in multiple centers in the US. And that study, they concluded that OSA was found to be 100% with respect to AHI and RDI scores, and concluded that it is a successful form of treatment for OSA. Now, this was a 15-year study, a review of the cases done. So let's look at one patient that we did some time back. He was a 26-year-old, rather drastic in appearance, because he's not one of those who has normal anatomy. When we looked at him, he has this typical bird faces, which you would otherwise orientate with disorders like temporomandibular joint ankylosis, but that was not the case with him. He had congenital deficiency in the mandible with almost a negligible chin, and needless to say, he was snoring. He had excessive daytime sleepiness, and he was a mouth breather. And these were all the findings we found in him, which is not, I mean, all of them actually would tell us that this is a patient who needed some sort of active treatment, and an MMA was what was offered to him in the first instance. So I will just show you this little video. If you can see, they should be able to see this.
Yeah, we are able to see.
Right. So I will enlarge this, and there we are. So this was what was the situation before the surgery. Dr. Srinivas did this, and you can see how much of collapse of the tongue base is there onto the airway there. It's not my job to comment on this, although I'm not the right specialist to talking about this. But yes, so that was what it was like. And then right.
Press escape. Press the button escape, and then you should be able to do it.
Escape.
No, now again.
Yeah, now. Yeah.
Escape.
No, now escape.
Yeah. No, press it. Press escape.
Okay, come out of it then.
Yeah. Stop share.
Okay. Sorry about this.
You'll have to restart sharing.
Okay, no, that's all right. This is going ahead now. Can you see this?
No, you have to start sharing your screen again. We are able to see you.
Okay.
Vikas, are you
Yeah.
the host of the panel?
Yes.
You should allow to screen share. You are just the only man who can do it. I think you need some computer work also. If you are the host of the panel. Do you understand what I mean?
Can you see this now?
No, honestly, we cannot see it, Gautam, right now.
Vikas, do you
Yes.
hear me?
Yes, I can. Can you repeat it?
Yeah. You are the host of the panel right now.
Okay.
So you should press to share the screen for the panelist. Without that, it's really difficult. There should be some button for you.
Okay, Dinesh, I'm actually not the host of the meeting.
Yes,
Host
sir.
of the meeting.
Correct.
Dinesh, did you understand what Dr. Mustafa is saying?
Yeah. Yes, sir. Can you tell me?
Okay, I think Gautam's screen is now seen. Gautam, go ahead.
Right.
Yeah.
All right.
Okay, Gautam, go ahead.
So looking at all his the patient I just showed you who had the FLP, looking at all his parameters, I mean, it doesn't take a big guess to understand that he was quite a severe case of OHA. That's just to give you an idea of what we are looking at, his desaturation index and his other parameters. Now, the Stanford protocols say that, you know, as of today, if soft tissue surgery is not seen as a viable alternative to treat this condition, then maxillomandibular advancement is what could be offered as the first stop of surgery for these patients. And that's exactly what we did for this guy. So what do we do before the surgery? As I explained a little bit before this in the other slide, we mount these articulators, we make splints, we sterilize them. Arch bars is what are required, dental arch bars. We could either place them one day before the surgery or even at the time of the surgery. And of course, we have all the other x-rays and the models ready with us at the time of the surgery. We don't need any fancy scans or anything like that for this. Fiber optic intubation is what we do because usually these patients have difficult airways and it's always a safe option to do it. I don't think, as far as I can remember, any of our patients needing a tracheostomy at all. And more often than not, these patients obviously need a nasal intubation because we will need control of the entire skeletal complex along with access to the occlusion in order to do this. So a nasal intubation is what would be required for this. So what are the surgical steps we follow here? We start with the sagittal split osteotomy of the mandible first. And having done that, we make the cuts in the mandible first. Then we go to do the osteotomy of the maxilla. And once we have completed the osteotomy of the maxilla and mobilized the maxilla and fixed it, we then go back to the mandible and actually carry out the split to mobilize the mandible. And once we have done both of these, we advance the entire maxillomandibular complex to the degree that we want it. As a ballpark figure, we always try to do it anything more than 10 centimeters because although we fix these with mini plates, which we would like to call rigid fixation, they actually are semi-rigid internal fixation. So you could expect a little bit of relapse from where we actually fix it. So anything more than 10 millimeters is what we desire to do if we want to get an optimal result out of this. So what's a bilateral sagittal split osteotomy? In a simple term, this is an osteotomy in the mandible where you separate the dentoalveolar complex of the mandible away from the condyle and the ramus of the mandible. So that's where you split it. That is the sagittal split. So we actually split the mandible sagittally so that when we do this on both sides, we have a free dentoalveolar segment of the mandible, which we could move in any direction that we want. In this case, being as forward as we can. So that's how a sagittal split cut looks like. So we make 3 cuts essentially. We have a horizontal cut that goes along the body of the mandible, a cut that is vertical that goes along the body. These are the 2 cuts that you're able to see on these pictures. And we have another cut, which you can see on the picture above, the animated picture, which is on the lingual side of the ramus of the mandible. So 3 cuts in all. 1 cut in the lingual side of the ramus, 1 horizontal cut on the body, and 1 vertical cut down at the level of the first or the second molar tooth. Now, when these 3 cuts are joined, then we are able to actually split the mandible. And once we have done that, we pull the mandible forwards and then do internal fixation. As you can see here, you see that bony gap, and that's exactly what we desire. By the time we have fixed the mandible with the plate, we want to see that big gap, and we want to see bigger and bigger gaps, because we want to see that the mandible has actually come forward by anything more than 1 centimeter to get an optimal result. Turning to the LeFort osteotomy of the maxilla. The LeFort osteotomy actually incorporates the fracture lines as described by René LeFort when he described the fractures at the level of LeFort 1, 2, and 3 in the facial skeleton. So the LeFort 1 osteotomy is a low-level osteotomy which goes through the piriform fossa, the anterior wall of the maxillary sinus, and then turns around to take the cut right till the skull base, which is the pterygomaxillary junction. Once we've made these osteotomy cuts, we are able to then down fracture the maxilla without much difficulty. One of the critical steps here is the pterygomaxillary disjunction, as we call it, because unless we separate the maxilla from the sphenoid at the back, we will not be able to mobilize the maxilla well. And that's a critical point, because the direction of the osteotomy is very important, because pterygomaxillary disjunction gone wrong has been reported to cause blindness. So that's one area where we are very, very careful when we do this procedure. Once having done this, we mobilize the maxilla as much as we can so that we can advance it and fix it in the right position. There are some additional procedures that we can do while we are at it. And one of the procedures that I normally do with this is the advancement genioplasty, because that also brings all the musculature of the tongue forward along with the genium, and hence facilitates anterior positioning of the tongue. Now, what about the surgery? So, well, there we are. So we first start with putting the arch bars on in the maxillary teeth and the mandibular teeth. It's a little cumbersome to do it, but it's needless and it is absolutely important. Then infiltrate local anesthesia and then make the incision. We start with the mandible first. We make the incision in the retromolar area and lift a buccal mucoperiosteal flap. And once we've done that, we get down to the mandible straight away. And we then start with making the osteotomy cuts. And that's exactly what the cuts as I described. That horizontal cut on the body, that's the lingual cut, if you can appreciate it. And then the vertical cut at the level of the first and second molar tooth. Once all these cuts are joined, that's what it is going to look like. Now now it's not split yet. The cuts have been made in the mandible, and we make these cuts on both the sides. This is the other side that you're looking at. And we don't split it. We make the cuts and we wait. We don't split it yet. We go to the maxilla now and then make a buccal sulcus incision in the maxilla. All along. It's always safe not to carry the incision too far back, because by way of retraction, the incision itself gets longer and longer. So you've got to be a bit careful there. We don't do it any more than the first premolar tooth. And once we've done the lifted the flap, we expose the piriform fossa, and those are the osteotomy cuts which we are going to be making now. And so we go through the piriform fossa, that's the anterior wall of the maxilla, and then take it backwards, as I said, right till the sphenoid. And then we make the cuts on the other side. So basically, it's about dividing the nasal septum and the lateral wall of the nose. And that's the osteotomy going right till the sphenoid. And that's the nasal septal chisel, which is helping us divide the nasal septum. And once we've done that, we're down fracturing the maxilla now. We're just separating the maxilla from the skull base at the moment. And this is the point at which it might bleed a little bit. But if you've been in the right planes and subperiosteal, then usually there is not much bleeding that we encounter. As you can see here, we can't see much bleeding. Now we're mobilizing the maxilla. Now all the cuts have been made, the maxilla is free. So we actually take this rose disimpaction forceps and properly in every dimension, XYZ axis, we have to make sure that the maxilla is absolutely mobile and free from the skull base. And once we have done that, so this is the view. I want to show you the palate here. So at this stage, the maxilla is like a pedicle flap. It's like a pedicle flap, which is based on the soft palate. So we bring the maxilla forwards as much as we can. In this case, it was about 12 millimeters. And we do fixation of the maxilla with mini plates, 2 in the pyriform fossa and 2 in the zygomatic buttress area. We're now turning our attention to the mandible. We're now beginning to split the mandible. And there we are. There is the sagittal split, as we call it. So we're splitting the ramus away from the dentoalveolar segment. That's mobilized. And we turn our attention to the other side, do the same thing on the mandible on the other side. That's the inferior alveolar neurovascular bundle. And once we've brought the mandible forwards, we again put maxillomandibular fixation and now fix the mandible with mini plates. Now, having fixed the mandible bilaterally, we now turn our attention towards the genioplasty. So make this anterior labial sulcus incision and then do a mucoperiosteal dissection. That's the mental nerve, just about visible there. And then we make the cuts in the chin, bony chin, and mobilize the genio. Remember, the backside of the chin has the genioglossus. So that's what happens when you bring the chin forward. There, we're bringing it forward and back, just to appreciate how much of movement can be caused by doing an advancement genioplasty. And similarly, we fix the bony chin, and there we are. Now we have completed the maxillomandibular advancement with the maxilla and the mandible fixed in their new position. That's about 3 hours of surgery, just put down to 5 minutes, less than 5 minutes of video. Believe me, it's not half as easy as it looks. So, what are the immediate post-op complications that we could encounter? Hemorrhage, we know this. I mean, this is not new to us. Any of us doing surgery are aware of all these factors. The additional little alarming for the patient is the amount of edema and swelling that we see post-operatively, but with lots of steroids, we can always keep it down.
Yeah, that's
yeah.
We'll do it later.
Okay, we'll do it here. I will show you the scope. Yeah, we'll do that later. Now, one of the important things that we see is quite a significant facial change, because when we bring the entire maxillomandibular complex forwards with the chin, definitely the profile improves. And if you appreciate here, you know, we've gone from that reduced lower third facial height to an increased lower third facial height. So that's something we need to watch out. It's a small thing, but you know, something that we should remember when we are seeing these patients with these problems. And that's the post. I mean, if you're able to appreciate it on the X-ray, I mean, that's where it looked like, you know, the airway space looked like on the lateral cephalogram before we did the surgery. And that's how much we were able to expand it to post. Quite significant on the X-ray. From an intraoperative perspective, bleeding, yes, two of the common areas where we could encounter bleeding is the greater palatine when we are down fracturing the maxilla and the inferior alveolar neurovascular bundle. And an unpredictable mandibular split can be very painful to deal with, and extreme care and caution should be taken there. Post-operatively, yes, we could have some malocclusion, not something that's very much out of the way. Some of the patients might need post-operative orthodontic treatment, so just align their treatment to the right place. Non-union is another problem. We don't encounter it frequently, but it's quite a possibility. Yes, paresthesia of the lip and chin is something that almost every patient is going to have after this surgery, which takes a few weeks to resolve unless otherwise we have created an inadvertent axonotmesis which might take even longer to get back to function. Well, what could cause failures of this surgery? Inadequate advancement. If we're half-hearted, we don't go all the way. As we said, 12 millimeters is approximately what we're looking at. So anything less than that really, after this kind of surgery is not going to benefit the patient a lot. And any post-operative weight gain and, patient non-compliance can always lead to failure. We've operated on quite a few patients, and that's been our result, 20 male, 25 female patients, and those were the pre and post AHIs that we were looking at. This is over a 4-year period. We've had many more before that. But I would say on the whole, we've had quite a satisfying result with MMAs. Yes, we do joint clinics. We've been able to create that service, and with state-of-the-art equipment and everything that's available to us in one roof, with what we can possibly call the best of facilities and experience and skill. We've been able to get to this point of having the largest scale. So what would we say in conclusion? Sure, MMA is one of the most efficient surgical procedures for OSA. Should it be the first line of treatment? I don't know, I might be lynched for saying this on an ENT meeting, but maybe more and more as we look forwards, could be the one-stop treatment for OSA. With that kind of success rates, relatively safe, because again, what I would like to reiterate is this is not a procedure that maxillofacial surgeons do for OSA alone. Maxillary and mandibular osteotomies are always done for cosmetic purposes and other facial deformities. And on the whole, we don't see any alarming side effects or complications in the long-term perspective with these. So complications are relatively minor, and it's quite a safe procedure to do otherwise. And that's our team here. And I hope that was quite beneficial for everybody listening to us. Thank you so much for your patient hearing. Yeah.
Stop sharing.
Great, Gautam. I think it was just wonderful. We all loved it. And there are a lot of questions that all of us want to ask. And there are a lot of questions coming in. But first, let me invite Dr. Mustafa to try sharing his presentation. And if we can listen to him. See, we understand. Dr. Mustafa, can you try sharing your screen?
Yeah, I'll try.
Yeah. While Dr. Mustafa is sharing the screen, I would... Gautam, this surgery looks pretty big. Yeah, I think Dr. Mustafa's screen is here. So since
Is
Dr.
it okay right now?
Yeah, it's wonderful. So I think I'll invite
I can
Dr.
stop
Mustafa.
it and I can wait.
No, you're absolutely fine. So I invite Dr. Mustafa Gerek from Turkey to give his presentation on tongue base and epiglottic surgery. The point is that howsoever effective is the maxillomandibular advancement surgery, it's a pretty big surgery. And we want to know from you, Dr. Mustafa, how we can do surgery for all grades of small and large tongue bases and epiglottis. So please go ahead. Thank you.
Thank you very much. Actually, it's a great honor for me to be with our dear friends in India, because I have very good memories from about your country. A few years ago, I have a chance to visit the New Delhi, and our dear friends, the Professor Patel, Srinivas Kishira, and also my close friend Vikas and Vijaya. Thank you again for inviting me to here again. And in this time, we talk about tongue base and epiglottic surgery in sleep apnea. When we actually, if it's going to be the first lecture, it will have meaning. That the pathophysiology, when we look at the pathophysiology of the upper airway, tongue plays an important role here, and it usually obstructs the airway. Is my voice clear there?
Yeah, very clear, Dr. Mustafa. Go ahead.
Just a moment, because...
Yeah. Everything is good. Go ahead.
Kendimi göremez mi? Demin görüyorlardı, göremiyorum. Okay.
No, you can go to the next.
Okay. Let's go from there. Because I couldn't see myself on the screen also.
Dr. Mustafa, everything is going all right. You proceed.
Okay, okay, thank you.
We are able to see you well.
Okay, thank you, thank you.
Yeah, go
thank
to the
you.
next slide because this slide has a lot of sound. So go to the next one.
Okay, 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 okay. Let's
Perfect.
do others. And
Yeah.
here you see the tongue base plays very important role. As you know, just a moment. I'm not very good at the computer. Can you change it to myself? Just I want to see myself. Yeah, here. Okay, 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 okay.
Yeah.
Okay.
We are able to see it very nicely, Dr. Mustafa.
Okay, okay.
Yeah.
Bu tarafa, bu tarafa, bu tarafa. Heh, tamam. Tamam, peki, peki. Tamam, iki kişi de kalsın. Bir kişi benim kalsın sadece, ben kalayım. Tamam, o zaman şey yap.
So it's very clear, Dr. Mustafa. We are able to see you very well, and you can continue.
Okay, but I couldn't see myself there. This is the problem.
No, we are able to see you. We are able to see you. Don't worry.
Just okay.
Yeah.
Okay. You know, as we know that the tongue base is very important up at the sleep surgery, because the hypopharyngeal or retrolingual obstruction usually related with the enlarged tongue, seen here, or more commonly, as my previous speaker talked about, the maxillomandibular deficiency. And usually our surgeries are aimed to enlarge the airway from the nose down to the hypopharynx. So the distance between the posterior pharyngeal airway and the tongue base should be over 12 millimeter in normal adults. It's usually lower than 8 millimeter in severe sleep apnea cases. So we must increase the distance between these two anatomical landmarks. So tongue base is very important, as seen here. Any pathology obstructing the airway resulted with sleep apnea. So for successful surgery for the tongue base, usually depends on proper patient selection, proper procedure selection, and also it depends on experience of the surgeon. And these are the classical PREOP evaluations of any cases in sleep surgery. And also the tongue base is very important. And for selecting the patient for the tongue-based surgery, drug-induced sleep endoscopy is very important. And if you found any special findings at the tongue-based level, maybe mid-sagittal MRI plays or give us more information to see what's happening here. Sometimes the skeleton also can obstruct or narrow the airway. So in order to understand any pathology at the tongue base, maybe a sagittal MRI gives us more information. And this is one of my picture, maybe 30, 25 years ago, while doing fiber optic endoscopy. At that time, we are using the usual Muller maneuver because at that time we only know that one. But luckily, we are now using dyes to detect proper obstruction level at the upper airway. What are the surgical techniques commonly used for the tongue base in obstructive sleep apnea? These are tongue-based radiofrequency ablation, tongue-based suspension techniques, submucosal lingual excision techniques, transoral robotic surgery, hypoglossal nerve stimulation. And I'm going to talk about on each of these topics. The higher suspension techniques and genioplasty techniques are seldomly used nowadays because we know that the other techniques, the previous techniques, gives us more chance to enlarge the airway at the tongue-based level. The tongue-based radiofrequency ablation addresses the tongue base by three mechanisms, which are tissue reduction, improve the tension at the tongue base, or increase the airway space. For having these good results, usually we ablate the central portion of the tongue at the level of the foramen cecum, 10 to 12 spots, which are targeted, and we give energy which should not exceed 750 joule for each size. And usually this technique is repeated or needs to be repeated because the long-term results are not satisfactory. But in the early phases, it can be used as a part of a multi-level surgery in sleep apnea cases. But honestly let's say that we are stopping or we stop to use these techniques anymore because we have newer instruments to give us more chance to enlarge the obstruction or the airway levels at the tongue base. We will talk about later. And also the radio frequency in the early phases give us a little bit help, but the long-term in the long-term follow-up, the results are not satisfactory, as I said before. And it has some complications also. Sometimes it may cause abscesses or may cause some bleeding. And one of the cases I know that not in my department, but in Ankara, in Turkey, need to be tracked because of the severe bleeding after the radiofrequency ablation. And the other technique I'm going to talk about is tongue-based suspension suture techniques. These techniques, which I like in some certain cases, it's very helpful and it's very easy. The procedure that enlarges the retrolingual airway and increase, or at least to prevent the collapse of the retrolingual airway spaces. There is I want to share two papers recently. One of them is published in 2018 by Stacy Eichmann from Cincinnati. Also, she says that in this paper, tongue suspension suture can be used in pediatric cases. And the other paper from the Far East, the tongue-based suspension, which is they use repose system, is a part of a multi-level surgery. They use it and they have successful results, good results in Fujita type 3 collapse of the patients. And the other paper comes from Turkey many years ago, a close friend of mine. He said that in his paper that the success rate is a little bit higher, but in my experience, the tongue-based suspension suture technique, which should be a part of a multi-level surgery, give us chance about 60–65%. But let me share in which cases I prefer to use. This is one of the cases, the polysomnographic evaluation. You can see that the obstructive episodes are all happen in supine position of the patient. In the non-supine position, it's just 2 episodes, but in the supine position, 224 times the patient has apneic episodes, which means that the laxity of the tongue base obstruct the airway. If we stabilize by using suspension suture, the patient can easily breathe without obstruction during the sleep time. I usually, instead of repose technique, we a little bit modified the previously mentioned technique. We open a hole through the mandible, and we put a 0 nylon suture there. We stabilize it, and there is a needle carrier here. It's very cheap, very easy. Just through the midline, we pass the needle under the tongue, through the genioglossus muscle, to the tongue base. Here, the patient has also anterior palatoplasty at the same time. This is the 0 nylon suture and the needle holder. And we release the suture from there. And we get a free needle, like the general surgeons usually prefer many years ago, and just passed around the tongue base, nearly totally 1.5 centimeter just in the midline of the tongue base. And after getting it from there, and the free needle is taken out. And the suture is released from the needle, and passed again from the needle holder, like this one. We will take it back. And you see that when we take it back, this is the epiglottis, this is the epiglottis here, and this is by putting some tension on it, the tongue base, we will see it again. Yeah, there's some, yeah, you see that this is the epiglottis, this is the tunnel, V-shaped tunnel here. Even the tongue base go backward during sleep in supine position. There should be a tunnel that the air can easily go. This is the first week after the surgery, and this is another case, 7th year after surgery. You see the indentation here, even, yeah, there is a tunnel, and it seems that the tongue is going to be more stable. And the post-op polysomnographic evaluation of the case I previously mentioned, which is here. I need to use the mouse. Yazmak istemiyorum ben. Sadece göster bana tekrar. Şöyle mi göstereyim? Hayır. Bunu da göstereyim ben. Burada şey yok mu? Mouse göstermiyor mu burada?
Hocam kalemi de kullanabilirsin. Text de kullanabilirsin.
So,
Nasıl gelecek buraya?
Dr.
Yes,
Mustafa, in the
yeah.
full screen mode, the mouse may not play, so you can go off less than full screen mode, and then you can use the mouse. The earlier one you're using, it was showing.
Okay.
Çarpıya da basıp çıkabilirsin.
Just
hocam.
press escape, so you'll get into the non-full screen mode. Press escape.
No, it doesn't.
Okay.
It doesn't running. Even we.
Mouse'unu mu çalışıyor hocam?
Okay. Okay. Here, the previous one in supine position, the 224 is lower to 12.
Right.
Yeah. After 8 months, it seems to be that also the oxygen desaturation, which is very is come to easy, and the apnea hypopnea index lowered from 37.2 to 1.8, which seems that if you have a proper patient selection, tongue-based suspension suture is very helpful. I will talk later, but it's a little bit painful and needs to be a close follow-up for a few days in your IC unit or in the department, actually. But otherwise, the long-term results are also very satisfactory, I believe. Maybe. The escape mode stop also.
So go to the next slide if you can.
No, I couldn't go even further. Just be.
Yeah.
Okay.
You're there. You're
We're
there.
locked there. Let me check.
Yeah, it's working. We can see it.
No, but.
Sağ klik.
Okay.
Correct.
And one the other technique is we commonly use to enlarge the airway at the tongue-based level is coblation with the coblation instruments, and these are techniques or smile or SAL procedures. We know that the tongue base has a fatty tissue. If you get, or maybe there's some relation between obesity and the sleep apnea, should be focused on here, or lymphoid tissues at this level also decreases the caliber of the airway at the tongue base level. So our aim is to reduce the volume at the tongue base level, even by removing some fatty tissue or lymphoid tissue at this level. For this purpose, we have some new techniques. One is known as Ablation, tongue-based surgery, and the other one is cell techniques. This is a lightening of the tongue to enlarge the airway, which is Excision from San Francisco, Los Angeles. He introduced it a few years ago. And also Ahmed Baghdad from Egypt, a close friend of mine. Also, he is very actively using Ablation for the tongue-based surgery. And they said in both papers, Ablation seems to be more helpful than the other techniques to enlarge the airway at the tongue-based level. And I want to show you some cases. For also tongue-based, we usually rely on the DICE findings because epiglottis and the tongue base usually act together if there is a hypopharyngeal obstruction. And sometimes cases with huge tongue in the mouth also have difficulty in breathing and resulted with pediatric sleep apnea cases. In such instances also, we should decrease the whole tongue volume. In such cases, I usually prefer Ablation instrument to remove the tissue at the tongue base level as much as I want. And I usually prefer to use hand Doppler. We generally know that the neurovascular structure of the tongue, and we know that the midline of the tongue is very safe, but in order to prevent any anatomical abnormality in the vessels, we have a hand Doppler in the department, and I want to use it to localize the vascular structures. And in the SMILE procedure, you know, here, we usually retract the tongue by putting a suture from the midline. And either you can make a little incision and through a tunnel, you can remove the lymphoid tissue over the muscles at the tongue base level or the fatty tissue, or you can make an open procedure, which I usually prefer because the open procedure are more safe to control the bleeding and to control the Ablation instruments because you can see everywhere in your surgical field. And here, just for opening the midline incision, you can use Bowie, which causes less bleeding. Then with the Ablation instruments, you can remove the lymphoid and the fatty tissue at the tongue base level. And when you come so close to the muscles, it usually began to shake, which means that you should stop there because we usually didn't want to remove the muscle tissue. And also it gives us a little protection because we know that the neurovascular bundle is usually under the muscle if there is no. This is the epiglottis is here. And if there is enough tissue that you think that you removed, you can stop. The Ablation is a very good instrument because it irrigates at the same time, and also you can easily stop bleeding, control bleeding. So it gives you a clear surgical field during the procedure. And this is another case that the child, the tongue is too big in the mouth, as you see here. So we can remove some part in the mobile part of the tongue. I like to use Bowie because it gives us less bleeding, and also I can remove some muscles from the midline. Midline is always safe. If you stay midline, you can remove as much as you want, and then we put a suture and close the muscle to muscle first, then the lingual mucosa. And the patient can easily keep the tongue in the mouth, and you see it is mobile to both sides, so which means that there is no. And while you are doing a coblation, I usually do not put suture to the end of the backside of the incision line for any kind of drainage, because if you completely close it, maybe it may cause some seroma or abscess formation. But if you leave a few stitch size open, it helps you very well to prevent any kind of seroma. And this is a case, you see that the vallecula is filled with lymphoid tissue, and a year after, if there's some little lymphoid tissue, but the vallecula seems to be clear. So you can repeat the lingual excision again if you wish, but seems very clear in this case, and it seems very helpful to the patients. And my personal thought about the coblation is a very helpful instrument. It is very easy to use, the less complication we have, and also it's very cheap for the patients if we compare it with the robot. Because for the tongue base, we usually use coblation or robot. A robot needs a time-consuming procedure for setup, and also it comes a little bit expensive to the patients, but it has advantages. Both of them has some advantages for themselves. The coblation has less pain than robot or tongue-based suspension procedures, and the healing is very good, but it has also complications I will talk about after the robotic procedure. And the transoral robotic surgery is very commonly used in the recent years if you have this instrument in your department. And it has some advantages when we compare it with the other lingual resection techniques, because the traditional tongue-based resections have some limitations, significant limitations. Usually the visualization and the dexterity is important and advantages of the robot. And the godfather of the robot, you know, Claudio Vicini and his very close friend Montevecchi together, they introduced it to the world, and the robot is begun commonly used for sleep apnea. It has some benefits, some advantages, as I say before, but also it has also some limitations, I believe. For the transoral robotic surgery, also DICE is very important. As seen here, the tongue base and the epiglottis is very important. Or in sagittal MRI, if there is a lymphoid enlargement growing like this one, maybe a robot gives you more chance than any other techniques to enlarge the airway at this level. Also, when we look at the indications, it should be moderate to severe sleep apnea which is confirmed by a sleep study, and failure to tolerate or comply the other also treatments, including CPAP and mandibular advancement device. Actually, in my country, the mandibular advancement devices are less commonly used, and the patient should not be morbid obese. BMI should be lower than 35. It is in some cases we operated up to 40 BMI, but if it is over than 40, we usually send them to our bariatric surgeons to evaluate the patient whether they have chance for any kind of bariatric surgery to lose some weight. And some of the cases benefits too much from the bariatric surgery, and they do not need or want any kind of other surgery for their sleep problem. Usually they have a problem gone. And the epiglottis in the robotic surgery should be carefully evaluated during DICE, because during the robotic surgery, we can easily touch to epiglottis if there is a problem. But sometimes we perform robot just for epiglottis in cases the tongue base do not have problem. And also it has some contraindications or limits. Coagulopathy, which is very important because we are working on the tongue base. If there is a bleeding or severe bleedings, it is really difficult to control in the post-op period. The morbid obesity I talked about, and immunocompromised patients, as always, it's contraindications for any kind of surgery, I believe. And limited mouth opening or mandibular deficiency, if it's happened, I usually send these cases to our orthodontic surgeons for any kind of treatment modality they can offer, or be operated as mandibular advancement or maxillomandibular advancement, which we perform in my department. And when we, it is not strict contraindications, but we want to follow up the patients. If the patients do not want to come for the post-op follow-up period, we do not want to do robotic surgery to them. How we do it, the robotic surgery for the tongue-based obstruction in sleep apnea? Nasotracheal intubations is performed, which gives us more help to access the tongue base and epiglottis. Boyle-Davis cake is used to open the mouth, and there is a roll, shoulder roll, to keep the patient in supine position. The removal of the tissues at the tongue base can be done by triangular type resection or pyramid type resection. It can be used both, depends on the anatomical variations of the tongue base that the patient has, but both is possible. But the important thing is the neurovascular structure at the tongue base, because during the robotic surgery, you have a huge wide file and you want to remove too much tissue. Because in the coblation, you have some limitations because the tongue began to shake and you couldn't reach the end of the tongue base. But during robotic surgery, the visualization is so great and you can see it 3D, and you want to remove too much tissue. So you must be very careful, especially for the young surgeons, I mean, must be very careful because the neurovascular structures are usually at risk, and the transoral anatomy knowledge is very essential if anybody wants to do the robotic surgery. We usually try to keep in the midline, and we do not want to reach over 1.5 centimeter through the midline midline of the tongue base, because if you go more than 20 millimeter lateral, that the hypoglossal nerve and the lingual artery may be at risk. So we must be very careful. And the amount of tissue that removed from the tongue base during the robotic surgery usually depends on the balance against the potential morbidity and the functional results both. But you know, as I said before, the robot gives us more chance to remove as much as tissue should be removed from the tongue base, because it's a very good technique or option to see the old part of the tongue. And so usually we also touch to the epiglottis or the upper part of the epiglottis to enlarge the area at the tongue base level, because epiglottic remnant should be kept there in order to minimize the risk of aspiration as well as good results. Here you see irrigation. This is the epiglottis, and also we evaluate there is any residual tissue that should be removed or not, the tongue base, and the epiglottis here irrigated, see any kind of bleeding or not. Usually nasogastric tube insertion and tracheostomy were not required, most of the patients, And we want to keep the patient in our ICU unit and overnight, and in the department at least 3 or 4 days in the post-op healing period, any kind of bleeding or any airway problem. Usually the patients received in the perioperative and postoperative steroids to minimize the edema, nose, and pain. Antibiotics are also given, analgesia. Sometimes the patient control analgesia also given in the post-op period in the department. It has minor bleeding, dysgeusia, or some odynophagia to solids as a minor complications after surgery, and usually commonly result in 4 to 6 weeks. But some severe complications which needs the patient to be tracked sometimes may happen. So the surgeons in the department should be carefully follow up the patient at least for a few days. And there are some papers about the transoral robotic surgery in sleep apnea. What are they saying in this paper? These are meta-analyses, so I want to give the results. The cost and the comorbidity is regarded with the other techniques a little bit higher, they say, but the visualization and the precision of the surgery has advantages in the transoral robotic surgery. Probably in the future years, the robot's going to be more easier to do, and the arms maybe become more cheap, and we can. I believe that for the tongue-based surgery, it becomes more commonly used than the other techniques. The efficacy, when we look at the robotic surgery, it is very promising surgery, I believe, because by the robotic surgery, we can remove much tissue than the other techniques. And here, I want to give you a case, actually, through a case. In this one, the apnea-hypopnea index is 35.9, and after, this is the 15th day post-op period, and in this patient, after 3 months, it's lowered to 4.5, which is a little bit earlier, but probably the patient would benefit more from the transoral robotic surgery. Epiglottis. Epiglottis is another important anatomical landmark at the tongue-based level in sleep apnea. This is Robson Capasso, a close friend of ours, and his friend's paper published in Laryngoscope 2016. And it is also a systematic review. And most of the drug-induced sleep endoscopy studies shows that they found epiglottic collapse. And the epiglottic collapse is higher than the previously described in the literature. So it's very important. As seen here in this video, you see that the epiglottis, just during inspiration, it blocks the airway. And here, that the omega-shaped epiglottis usually seen in the patients who have sleep apnea for a long time. The epiglottis is deformed. Actually, in this case, the patient came us with a CPAP failure over 16 millimeter water pressure, and we found that the epiglottis is collapsed. The epiglottis is blocking the airway during inspiration. So we want to do surgery instead of insisting to use CPAP to the patient. And also, epiglottis may be the cause of snoring in some cases. And also, if the patients lay down laterally during their sleep, maybe the epiglottis collapse may be easier. And as I said before, the CPAP also, during the CPAP failures, we must use dyes and can commonly see this type of epiglottis because of the laxity of the epiglottis. which needs surgery. For epiglottis, we are using two instruments, Ablation, which is easier to do it. If it's as a single procedure, Ablation seems to be more easy to do it, less complication, no need to set up. In the early, this is the early picture, late picture, and just a week after the surgery. So the epiglottis couldn't obstruct the airway during inspiration. And with the ablation, we have less a problem in the post-op healing period in swallowing or aspiration. But during for the robot procedure, probably we couldn't stop our hands to remove less tissue. So we remove much and we have much complication. And this is the epiglottoplasty or supraglottoplasty, whereas epiglottis is a problem. Do I have time?
Yes, we have all the time, Dr. Mustafa.
Okay,
we are enjoying your presentation.
Okay, because I couldn't stop myself talking. So
No, we have all the time. Go ahead.
Okay, thank you. And with the bovie part of the robot, the free edge of the epiglottis is removed. So we shouldn't remove all epiglottis because of the stabilization. They usually healed very easily. Also some lymphoid growth at the tongue base level, which can be easily removed by robot. Oh, sorry, fast. Yes, yeah, the lymphoid tissues. Actually, with the robot, it seems very easy to remove, and you can check again, and if there is an excess or tissue that should be removed, you can go again and remove them as much as you desire. And if there is a floppy epiglottis, also we sometimes remove the mucosa of the epiglottis to the valvular side. So the mucosa is removed here, it's peeled, and there is a snake here of the epiglottis to the tongue base instead of removing it. This is another technique. Also, less complication, less pain after the surgery, and it never obstruct the airway again. The patient do not aspirate, and the airway seems to be more open even. This is the case, and also it comes from 83.3 to 4.5, which is seems to be very helpful after 4 months. And what are the complications of the tongue surgery in sleep apnea? There are many different types of complications, but the most problem is the pain. Especially tongue-based surgery seems to be the most painful procedure. So when you do a tongue-based suspension technique, you should keep the patient in the department, and the patient control anesthesia bolus, usually propofol, usually treat the patient's pain and needs to stay sometimes up to 7 days in the department. And we have studied single stage, multi-level, and the complications, velopharyngeal and hypopharyngeal procedures in terms of these problems, pain, difficulty in swallowing, velopharyngeal insufficiency, minor bleeding, vegetation, and some complications after the surgery. And when we look at tongue-based suspension, it seems to be more painful procedure. And also, there is a breakdown of a suture of the tongue-based suspension technique, and there seems to be edema at the tongue-based level because of the suture pressure to the muscles just beneath the mobile tongue. And here, another case, the patient has tongue-based suspension and antropolatoplasty and too much edema at the tongue base. And there is a bleeding. This is a patient after ablation, bleeds. Usually minor bleeding can easily be controlled by cold water mouth gargling, but sometimes needs to be taken to OR again and to control. And unfortunately, a few years ago, also we lost one of our cases after ablation surgery to tongue base because of bleeding. She coughed. She began to cough at 5 a.m. early in the morning, and after then she was bleeding just after the seventh day post-op, seventh day of the surgery. Even our friends intubated and take the OR, and the patient resuscitated a few times, and in the same day she passed away. This is the most complicated post-op patient we have. I'm going to talk a little about the hypoglossal nerve stimulation. It is one of the novel techniques recently used in most of the part of the world. It's because the technique depends on the genioglossus muscle activation by hypoglossal nerve stimulation. And by this stimulation, the tongue protrusion and prevention of anteropharyngeal wall collapse enlarge the airway at the tongue base level. It has some advantages, even the cost is very high. These advantages, one of the most important advantages is it's a procedure that is titratable and adjustable, as like a CPAP or oral appliances, because in the post-op period, you can adjust the instrument according to the need of the patient. It is reversible. You can take it out. There is no anatomical disturbance or anatomical removal. So it has some advantages, but the most disadvantage part of it is one of the price of it. For example, most of the Western countries, they began to pay it and included it in their insurance coverage, but in developing countries, it's a little bit expensive. What are the indications? Usually retrolingual obstruction, it should be, and CPAP compliance problem. And the apnea-hypopnea index should not be more than 30, but this is questionable because usually some of the patients may have more than 40. And the desaturation is very important. If it's more than 10% fall in the oxygen level, this technique is not good. And if the patient has central type apnea or implantation before, like cardiac pacemaker or cochlear implants, these are also the relative contraindications. My experience is very limited with the Aura 6000 product of the Inter Medical Company. In Turkey, I operated about 11 cases, and the other company do not have distribution in Turkey, so I do not have experience. And in the last years, it is excluded from the social coverage of the patients because of the price of it. In this one, there are 6 electrodes just covering the hypoglossal nerve, and different muscle groups targeted and stimulated at different times. So one muscle group is activated and the other one is rest, and the recover cycle is done by this one. I will show the video how we do it. This is the hypoglossal nerve, and we checked whether it's hypoglossal nerve or not for any movement by electric stimulation. And this is the cuff. I mean, it has 6 electrodes on it, and it is covered 260 degrees all around the hypoglossal nerve. And to keep it safe from any kind of tension, it should stabilize. And there is an IPG unit. It is usually placed just under the clavicle, under the size of, under the subcutaneously placed, just under the clavicle. And there is a tunnel just goes through the incision line to the IPG unit. And this is the cable of the 6 electrodes to the IPG unit. And it is locked. The end of the cable is locked to the IPG unit, which is charged transcutaneously every other day. And they said that the battery lasted up to 15 years. We will see. And this is the IPG unit. It is placed there. And with one suture, stabilize. It is actually, technically, it is very easy. This is the remote control. No, sorry. This is the remote control, and we began to, and the first simulation, we check it, and there is the 6 electrodes, each one is controlled. If at least 4 of them should be worked. And this is the first stimulation, actually, which is so high because it is not adjusted. And this is the schematic view of the instrument. And 4 to 6 weeks after the first stimulation, it is begun to adjust it. The patient awake in awake position. There is a program up to patients feel pain, up to tongue movement, and also during the polysomnographic evaluation, the stimulation protocol or adjustment protocol is finished, the polysomnographic evaluation. Then the patient began to use it. This is the first stimulation. Actually, a single side is stimulated, but both sides are began to open. And this is in awake position. You see here you see one side is stimulated and the muscle has tense, but the other part of the tongue is not that much. And there is some start trial work. All they say that the upper airway stimulation are successful and appropriate long-term of individuals with moderate to severe apnea. But probably, as I say, in future, we will use hypoglossal nerve stimulation more than now because it becomes more cheaper and easier to have it. And thanks again to everyone who are listening us. I have very good memories from your country.
Thank you, Dr. Mustafa. It was a brilliant talk. You touched on everything right from a tongue suspension to radio frequency to, yeah, can you stop sharing your screen? Can we have your video, Dr. Mustafa? I would. Yeah, host, can you make everybody live? Dinesh,
Yes, sir. Making.
make everybody visible. So, Dr. Mustafa, can you unmute yourself and start your video? Okay. So till Dr. Mustafa joins, Gautam,
Yes.
are you with me? Yeah, yeah. So basically, the question that people want to know is how much of retrolingual space you can create with maxillomandibular advancement.
That's a relative question, but on an average, I would say for every centimeter of movement of the mandible forwards, you can increase the space behind by about at least about 3 millimeters, I would say 1/3.
So suppose if you move the mandible forward by 1 centimeter, which is the maximum generally you can do with
Yeah,
MMA
more than
generally.
that, yeah,
So the retrolingual space would only come ahead by 3 millimeters?
3 to 4 millimeters, yes.
3 to 4 millimeters. So the question goes to Dr. Mustafa then.
Yes, yes, sir. Now I'm okay.
Yeah. So now you have a tongue-based obstruction, which you can do channeling, you can do coblation, you can do submucosal, you can do robotic, and you can do hypoglossal nerve implant. So generally, what is the kind of improvement in the retrolingual space you can get with the procedures like coblation or robotic?
A robot seems better in having too much distance between the posterior pharyngeal wall and the tongue base, but you know it has some limitations. Coblation seems to be more easier and can be repeatable.
No, my question is how much of space can be enlarged? See, we know that
usually, as I say, the distance between the posterior pharyngeal wall and the tongue base, if it's lower than 80 millimeters, the problem is beginning. And if you enlarge it over 12 millimeter, you usually have good results. And usually the patients can reach to this level, 4 5 millimeter at least. In the
4 5 millimeter, you can generally
in the sagittal weave of the MRI, which is a cutting through the mid sagittal section.
Right. And the question, Doctor, I think
Dr. Can I add just a point?
Yeah, please.
So you asked me about how much of retrolingual space you could create by advancing the mandible.
Yes.
So that's almost what I said. But remember that with an MMA, we are actually increasing the retroparietal space as well. So it's a double advantage that you're getting with an MMA, because with the maxillary advancement that we are doing, you get the additional advantage of creating space at the retroparietal, and you rotate the maxilla a little bit, differentially, as in push it more anterior downwards and posterior upwards. It just gives you more space. And there's even evidence to show that if you actually split the maxilla while doing the osteotomy, you get even increase in the transverse space. That's it.
When you remove mandible 1 centimeter forward, you usually enlarge the tongue base about 4 to 5 millimeters.
That's right.
Right. No, so I wanted from both the experts that, so then what is if we can get say 5 to 7 or 8 millimeter or even up to 1 centimeter, we can go inside the tongue by soft tissue procedures only, because the linguovascular bundle is always more than 1.5 centimeter inside. Then what is the advantage of doing maxillomandibular advancement? That's the point I was asking. Gautam.
Well, as I said, it's not just about the
distance at the. You told that it's also.
So you have to factor that space
also
that you're as well into that.
Correct.
Which probably you will not be able to do with only tongue base.
Totally agreed.
Also, the MMA has advantages that it has a very long-term good results. The other soft tissue resections may come to a problem again in future.
Right. There's a question from Dr. Eva from Poland. Thank you, Dr. Gerek, for the great presentation. According to your experience, what is the most effective vector to make the sutures during tongue suspension procedure to open up the airway most effectively? Did you understand? Dr. Eva
Yeah,
from
I
Poland.
understand.
Yeah. What is the most effective vector? So in what directions?
We usually take it to forward. We open a hole through the mandible, just under the mandible. The vector is usually seems to be from the longitudinal vector from the under of the mandible through the tongue base.
Okay.
Is it clear?
And yeah. And a similar question has been asked by Dr. Yogesh Singhal. He's asking that since it's a blind procedure, can you encounter any vital structure during that? You go through the midline, so I understand there's no vital.
Midline is always safe.
So there's no vital structure there.
Yep.
So that's the answer, Dr. Dr. Singhal.
If there's an anatomical abnormality, yeah, maybe bleeding or neural problem may happen. But up to now, I did more than 100 cases. I didn't have any kind of problem.
Wow. And what is the suture that you use?
A zero nylon suture.
Zero nylon, proline or nylon?
Yeah, proline, yeah.
Proline, okay.
Yeah.
And do you put one suture? He's saying that can you put one suture over the other?
One suture,
right.
It comes to the end of the tongue base.
Right.
It take it out and put in a needle and come it back.
Correct.
It seems that with the both sutures going in and out are so close to each other.
So they are parallel to each other, not above one each other. They are parallel to each other.
Parallel to each other, but in the same midline, so close to each other. But the tongue base, the grasp part of the tongue base is like a U shape.
Fine. Vidyasagar, you were asking some question. Can you unmute yourself? You wanted to ask.
Hi, Dr. Mustafa. Hi, thank you, Vikas.
Yes,
yeah. Hi, Dr. Mustafa. Dr. Vidyasagar here. Wonderful talk. Really enjoyed it. Thoroughly enjoyed it. My question is, if there is an epiglottic collapse alone in the dice, will the hypoglossal implant work for the epiglottic collapse also, a primary epiglottic collapse? What is your take on it?
I have no experience about it actually, but my thought is it do not work well.
It will not work well, yeah. So we understand, Dr. Mustafa, that the hypoglossal implant works on the soft palate.
Yeah,
it also pulls the soft palate?
No, the tongue base.
Yeah, but when the tongue is pulled forward, does the soft palate
lateral,
also?
Not the soft part, the lateral part of the tongue base, the structures are also come to the lateral when they have stimulated.
Right. But you think that the epiglottis may or may not be helped? That's the question Sagar is asking. Okay.
Yes.
Then Dr. Marina Carasso from Spain, she's asking, Mustafa, great presentation. Do you give just one suture or several at different levels?
For what?
For the tongue suspension. I think your tongue suspension is loved by everybody.
Yeah, it's very easy, cheap, and very effective surgery actually, because the reports, I don't talk about the companies, but it's expensive. It needs some money. It's about 1,500, something like that, $1,500 US. The other one is more cheap and more stable if the patient has purely supine type sleep apnea. You may have even positional therapy, but either you can use this suspension techniques, which comes more easier for me to stabilize the tongue base. I usually, the Marina's question is just a single suture, yeah?
So I think people want to still once more know that you go once, then you put the second one above it or on side of it. That's the question I believe people are asking.
No. Just think it as a tongue. Through the midline, go to the tongue base.
Correct.
Take the needle holder out. Another needle holder grasp the tongue base. And take it back, because I keep the needle holder there. I didn't take it out. Do you want me to show it again?
So you come back on top of it?
No.
Then?
Parallel.
Okay.
Parallel, because can I say it? It is going straight, turning like this and come back.
It's exactly.
So you pull it.
So this is the question everybody is asking.
So you just parallelly pull it out.
It's parallel.
Okay.
Yes.
Okay.
So it is just going like this. If you see like here, it is like a V. And then
it's like a U.
Pull in the
like
back, like a R. And it pulls the, posteriorly it is like a U.
So let Dr. Mustafa explain it. Yeah,
please, sir.
Cüneyt. Gel. Share the screen yapalım gene.
Yeah, because this is two, three people have asked the same questions.
Yeah, okay, okay. This is okay. Play yaptığım zaman oynayacak değil mi karşıda? Can you see the video?
Yes, yes, we
Okay,
can.
okay. We open a hole to the
Right.
mandible to stabilize our suture.
Right,
Yeah, just a hole.
right.
This is first we stitch there and take one side, I will keep one side a little bit longer. And there is a needle carrier here. This is a needle carrier, the suture carrier, I mean.
Yes, and you go
Just-
inside. We understood
Yeah,
that
inside
part.
just under the mandible, keeping the
Yes.
midline up to the, yeah, this is anteroplacid down, and
Correct.
this is the midline. This is the needle suture carrier.
Yes,
Yeah,
take it out.
I free it's
Yeah,
there.
it's out.
I keep it there,
Yes,
and I put another free needle to the suture, like this one, and grasp the tongue base. It's 1 or 1.5 centimeter. This part is a little bit difficult because the visualization and your hands, your instruments couldn't reach well, but yeah, it's a little bit, a
so
few
this
minutes
is
time
come.
consumed.
So this comes parallelly. So that was the question. Can you put it above the other? So we got it. Your technique is to put it parallelly.
No, just please.
Yeah.
Just please. And we pass the suture, and then the needle carrier, which is the suture carrier, which is there, still there. And I put it again. It is so close to each other, parallel and so close to each other. Yes, you're right. And then take the suture out again. You see the tension there on the tongue base. Yeah, you see the tension.
Wonderful.
And then this is the epiglottis you see, this is the tongue base, too much open space. And I tied the suture
Right.
over the mandible with the previous shorter part. And then here, epiglottis, this is the stable right now. After, yeah, you see the U-type opening here. And then this is the tonsils, the uvula.
Right, right. Perfect. So this was a request from Dr. Palanipan also to show the video again. So you've already done that. Thank you. Seema, we have a question to Dr. Gautam.
Yeah, Gautam, wonderful. Again, Dr. Mustafa, wonderful presentation. I'll come to that question. Gautam, we know all
Sorry,
know
Dr.
that,
Mustafa, can you stop sharing your screen, please? So that we
yeah,
can see you bigger. Just stop sharing the screen. Seema, one moment. Yeah,
okay.
Go ahead.
Right,
Go ahead.
Right. So to Gautam, when we do the MMAs, post-operatively, have you been doing something to assess the airspace improvement, volumetric improvement? And since we already know that, most procedures, soft tissue procedures, after a couple, maybe a year, 2 years, their efficacy goes down a bit. What is
No, Seema, we have gone mute. Seema, you have to unmute yourself.
So yes, coming
Yeah,
back to that question.
Let him finish the.
Okay.
Can you hear
Yeah.
me?
Yeah, we can hear you now.
I got that. So what is the result of the
No, again, we lost you, Seema. Not able to.
Have you understood the question, Gautam?
No.
Seema, you have to unmute yourself once more.
I think what he's trying to ask is, what do we do post-operatively to assess the improvement? Essentially, that's what he's asking.
How long post-operatively have you seen that the improvement remains that way?
Oh, I see. Okay. So yeah, I mean, my longest follow-up as of now would be about close to 7 years since we ever started doing this. Definitely 6 years plus. And at this point, I mean, I would actually correlate that very much to the study I showed in the journal that I was showing. That sure, I mean, the AHI at the time of immediate post-op surgery may not have been the same. I would like to admit, but far better at a 6-year stage than what it would otherwise have been. But yeah, that's about the longest.
Long-term follow-up. That's a good long-term.
That's the maximum follow-up we have. 6 years.
And you had some question for Dr. Mustafa also, Simon?
Yes, Dr. Mustafa, thank you very much for that presentation. Compliments. You mentioned about that complication that you had 7 days later with the tongue-based bleeding. So just wanted to know your protocol. Do you normally keep the patients in hospital for 7 days, or was this patient admitted because he probably came back with a little mild bleeding and you decided to observe her?
Yeah, the patient came after 3 days to our department because of pain. Okay. We keep the patient pain and swallowing problem.
So you kept her for 4-5 days?
Yep. Yeah, and after 3 days, we discharged the patient, lady, discharged, and sent home in the same city. And then after 3 days, she came back, which is 6th day after the post-op period. And the next day, actually early in the morning, she began to cough, and there was a huge bleeding.
So would you say that when you mentioned
your voice gone. Sim up, if you, repeat your question again, please.
Gargles and cold water gargles. So would you really advocate that, or would you, whenever you see even a mild general loose, go ahead with a coblation and just ablate all those vessels?
Is your question that you are giving mouthwash or cold water or something like that in all cases?
So how do you manage basically a small bleed versus the bigger one? That's
if there's small bleeding just on the surface of the mucosal bleeding, which is not a problem, we usually give cold water at first and keep the patient in the department.
Right. Srinivas, you have a question?
We do not send them home again. Keep the patient in the department. Yeah.
One question for Dr. Mustafa.
Yeah, Gautam.
Yeah, Dr. Mustafa, with these large tongue-based surgeries that you showed, particularly the tongue reduction surgery, do you actually extubate the patients immediately post-op, or do you keep them ventilated overnight? Or
and for the tongue-based or robot?
Tongue-based.
Tongue-based suspension, we extubated.
No, not suspension, the excision. When you do a large tongue-based excision with the robot or with the coblation.
All extubated. Extubated and keep, because I have chance, because in my department we have OR in the same building. We have our own building, so all our patients are in our site.
Okay, but in general, what will you advocate if a person is doing a tongue-based surgery, a large resection of the tongue base? Should it be extubated or should it be,
extubated but close follow-up?
Close. You should have a very, very good facility for a re-exploration if required.
Yep. Yeah, because we have anesthesiology guys in the department, in the building also.
Yeah, very nice. So I think Dr. Naveen Patel has a question.
Sir, I have a question for Professor Mustafa.
Yes, Professor.
So you have experience with hypoglossal nerve stimulation, which has an electrodes which are wrapped around the hypoglossal nerve.
Yeah.
And so instead of a selective medial or lateral stimulation, what you end up doing is stimulating the whole hypoglossal nerve.
No, but the stimulation is there are 6 electrodes surrounding the hypoglossal nerve. Usually 3 of them are working or 4 of them are working and the other one is resting. So it's like a cycle. 6 of them are not working at the same time.
So what were the patient's complaint? How do you decide that? How do you stimulate them? What is the way you take it stimulating, and how do you decide that this group of muscle will get tired, and what is the exact protocol will you follow?
Actually, I do not understand your question well.
No, I think that is taken care of by the algorithm of the implant.
Okay.
Yeah. So Dr. Mustafa, you have a question from Dr. Sandeep Sindhu. He is a very good friend of us and does a lot of work in obstructive sleep apnea. So again, yeah, you have met him in Delhi. Yes. So he's asking you how long the tongue suspension lasts, And have you ever repeated it?
I've never repeated it. If the suture do not break down, I do not repeat it again. But we do another surgeries because these are soft tissue surgeries. In time, the patient may have problem again, and at that time, I do not do a second time tongue suspension procedure. I do the other type of surgeries. But as far as I follow up, I have a cases which has 9 years.
Wow.
Before I did the tongue suspension, and still doing well. Do not any more surgery.
Perfect.
But some of the patients they have tongue-based problems, and we have coblation. At that time, also we cut the nylon suture there, and we removed and released the tongue-based, and then we did the coblation robot.
Yeah, Kishore, you have something to ask?
Professor Garrick, I have one question.
Yeah, good to see you again.
Good to see you again too. So my question is bringing you back to the suspension suture again.
Yep.
So my question to you is, in the post-op period, in the immediate post-op period, maybe day 2, day 3, have you seen any floor of the mouth hemorrhage that happens, and delayed hemorrhage that can happen and can cause any kind of because in that case, what happens? The entire tongue becomes
swollen.
Swollen, and then the whole tongue gets lifted.
As a complication, I usually see edema, not the bleeding.
Hemorrhage, okay.
Yeah, not hemorrhage.
So when there is if there is edema in the floor of the mouth, do you see the tongue going backwards?
No, yeah. Actually the airway narrowed at that time, but in time, in the follow-up period at time, also the when the edema gone, the distance between the posterior pharyngeal wall and tongue base getting easier and large.
So how long do you think, or when is the possibility that that can happen in the suture cases?
Yeah, if the suture case, usually they need 10 or 15 days to have less pain, easy to swallow. And after 2 weeks, they usually feel the benefits of the surgery during their sleep. Okay. If it's your question.
Yeah.
Excellent.
So there's a question for Dr. Gautam from Dr. Vidyadharan. He's asking, when do you do the genial tubercle advancement concomitantly with MMA? In which situations do you have concerns regarding vascularity of the middle mandibular segment? There are 2 questions.
Sorry, I didn't understand the second question.
Okay, the first question is, when you do the genial tubercular advancement concomitantly with the MMA?
Right. I would say more often than not. I mean, most cases where I would do MMA, I would do a genioplasty advancement because we are at it. We're in the same anatomical area, and that definitely gives. The only situation I would not do a genioplasty is when the patient has a very prominent chin otherwise. Because in that situation, if I brought the chin much more forward, then it would probably be cosmetically unacceptable to the patient. But
nice.
more often than not, these people are retrogenic, if you know what I mean. So it's
Correct.
always advantageous to bring it forward. Second question, please. What was it?
Yeah. In which situations do you have concerns regarding vascularity of the middle mandibular segment? So basically, when you do these osteotomies, does the mandible become avascular? Do you have concerns over the vascularity?
No,
I'm
not
sure you preserve the neurovascular bundle.
The main supply to the mandible comes from the inferior alveolar neurovascular bundle. And and it's not so just the neurovascular bundle, it's entire mucoperiosteum around the mandible that is a major blood supply also. So even if you actually busted the inferior alveolar nerve, you would not end up with the situation of avascular necrosis as much as in the maxilla. Even if you busted both the greater palatine vessels during the course, the blood supply comes completely from soft palate. So not a
There's a question from Dr. Vidyasagar. I think it's D. Vidyasagar to Dr. Garrick. Looking at the complications of bleeding or death, which you mentioned, post-coblation and robotic, do you feel that multiple application of radio frequency to tongue base would be a good option or a better option for an initial startup with tongue base surgery? So multiple applications of radio frequency, will it be as effective as a Excision?
No.
No.
Absolutely no, because the long-term results are not satisfactory, and you need to repeat the radiofrequency ablation to tongue base maybe 4 or 5 times between some certain intervals. And it's not an easy procedure it's an easy procedure for the doctors, for the staff, but it's not easy for the patient, and the patient usually do not want to have it after 3 or 4 applications. And the long-term results are not satisfactory.
I think that's the most important thing, that it's not easy for the patient to get it done again and again, and it's not as effective. So another question again for you, Dr. Garrick, is again from Dr. Yogesh Singhal. He's asking whether you use the electrode on one hypoglossal nerve or on both.
They are single side.
Yeah. Nowadays, that another implant is for both the sides simultaneously.
Yeah, but we do not have in our country right now.
Perfect. So this is for this, and even the single side tones up the muscles so much that it can.
Yeah, it seems to be effective to the other side during the stimulation.
Okay. And
but a double side is more effective, and probably in future it will be a part of a multi-level surgery.
So Seema has asked you one more question, that the post-op tongue edema that you showed in your video looked pretty big. How did you handle those patients? Did you admit them, put them on IV steroids, or just wait and watch? Because I mean, this is important for people to understand how will they manage if they get it.
That patient is my cousin. Actually, I very close follow-up in the post-op period because of being my relative. It's a complication. He has IV steroid in the post-op period, and also he has CPAP in the first 2 days after the operation. Then the edema can easily get easier in time, just in a week. And the patient, my cousin, has a good breath after that.
Very nice. Dr. Prakash Munka, he is one of our seniors from Bokaro. He's asking you, when would you decide to do a MMA as versus a soft tissue surgery? What is your criteria? Do you do MMA, Dr. Mustafa, or you do not?
Yeah, we are doing.
So then when do you decide to do MMA? If there's a gross retrognathia, then there's obviously no question. Everybody will do. But otherwise, if the face is looking normal, would you do a soft tissue procedure or would you go for MMA?
It depends. If the facial appearance, most of our patients has a normal facial appearance. The soft tissue sometimes to cover the skeleton. But if the skeleton has too much problem that we couldn't cover with the soft tissue procedures, we offer them to have MMA. But believe me that just only maybe 2% of the patients are accepting the MMA procedure. It's not easy for the patients. It's a time-consuming PREOP evaluation and preparation. And we must talk about the complications when we offer MMA. Most of the patients do not want to accept it.
Yeah.
But if they accept, they can easily have great benefit from the surgery.
Right. So I think we are coming to the end of our session. It's almost going to be 7, and there are a lot of questions. There's one more question from Dr. Marina Carasso.
Say hello to Marina for us.
Yeah. Hi, Marina. Mustafa. If you see the article of Stuck et al., where they did tongue-based radiofrequency and MRI pre and post-op, they showed that there was no reduction of the tissue at all after tongue-based radiofrequency. Do you agree with that? You said that is not so effective.
Yep.
So I think
I'm not using actually in the last 10 years.
Yeah. So I think we are pretty clear that efficacy wise Excision will be more efficacious, but if it is a very small tongue base and the surgeon doing the tongue base surgery is not greatly efficient at doing it, then he should not play very smart and go ahead and do a tongue based Excision, because you very nicely showed that even in expert hands it is possible to have deaths. So then play safe. Vijay, do you have something to share? You have to unmute yourself, Vijay.
Can you hear?
Yeah, we can hear you now.
Wonderful presentation. I'm just freezed. I think we have come to the end of this session. I would like to thank all the speakers, and I would like to play a small clip.
Wow.
Thank you.
Wow.
Thank you.
That's so nice.
This,
Super.
35 lectures we had with many international and national speakers. I would like to, this will be a concluding session and we will be coming back with another series. Thank you so much. Dr. Naveen Patel, sir, any words about?
It's a big thank you. It's a seed which was discussed with Amrish Sahayji and Mahendra Varmanji, and then Vijay joined hands, and then all the members of IASSA chipped in, and we could succeed and create 12 lecture series. And the 2 keynote series, probably I wish and pray to the God that we will continue with the keynote series and will bring you more and more keynote presentations via this kind of webinars. That's the feeling which I would like to express.
So I extend my sincere thanks to Dr. Mustafa for sparing your
pleasure.
valuable time, and Dr. Gautam to be with us and help us to understand the procedures. Your video on was excellent, but honestly, let me tell you, I have watched a lot of videos on YouTube. I do not do MMAs, but your video explained it really nicely in 5 minutes, what you do in 3 hours. So that was really great. And from all of us at IASSA, I extend once again our sincere regards from Seema, me, Srinivas, Sagar, and those who are not. Dipankar is not here today, Ranjini. We all extend our thanks, Mr. Ambrish and Mr. Mahendra, and the whole Sun Pharma team for having this webinar series for us. Thank you very much.
Thank you.
Thank you, everyone. Thank you all.
Thank you.
It was awesome to be with you all.